pediatría y la hipertensión endocraniana en pie. Usted es el doctor.
Good morning, everybody, and thank you again for having me here. It's been a wonderful visit for me. And this morning we're going to talk about the little people. The important thing to appreciate is that children are not small adults. They are uniquely different in their physiology and their anatomy. And as we think about this, we must understand that whatever evidence we have in thinking about adults, this does not automatically translate into thinking for children. So we need to be very sensitive to that difference. I have no disclosures. I had the privilege of visiting many parts of the Inca legacy in your country. And it's truly amazing because they, many years ago, found the perfect balance between art and science. These are magnificent artistic structures that they have created. And they've done it with infinite attention to scientific detail. In fact, these architectural columns that they created are renowned for their stability. And architects today battle to recreate something as effective as this. And unfortunately, we don't have that same wisdom. And in our business, a lot of it has to do with getting the balance between art and science correct. And this morning I'm going to try and help you to do that when we tackle these two subjects. If you've heard me before, you know that I love children's stories. I have two of my own, and so I have come to learn and understand why they're so beautiful. And Yogi Bear said, if you don't know where you're going, you will end up where you didn't want to be. Makes sense, right? But I don't think we think about that every day. We tend to forget that. And so when we got to do difficult things and make difficult choices, always remember where you are and where you want to be. And in doing that, you will be critical about things happening around you. So I'm going to talk a little bit about some basic concepts, give you some important background epidemiology, a few comments about developed countries, and then realities in low and middle income countries. This is the roller coaster of critical illness. If you consider being up here as being well, imagine this person who gets a hit, an insult from something. They rapidly decompensate when they're critically ill. And unless we intervene, they actually demise. If we intervene and do a reasonable job, they tend to get better. But very quickly they have a second hit. And the second hit is something that may be related to the initial problem, or it may be related to what we do or don't do. So it's important to understand that critical illness is not a linear process. It's a roller coaster. It's up and down. And our job is to identify how best we can get our patients to move up to the wellness zone and stay there. To measure sepsis, we've been fortunate in the STCM guideline to quantify severity of illness. And they made the nice distinction between what are infected causes, all of these, and what are non-infected causes. They further helped us by understanding about progression of disease. And remember that in the time frame of an illness, a person starting off normal and obviously getting progressively worse, declining over time, remember that we don't see this very easily in all organ systems. So somebody who's critically ill, you'll easily see that in the lungs or the cardiovascular system. They will become tachypneic, get tachycardia. But when it comes to the kidney and the liver, takes a long time before you see an abnormality there. So when you start off, it may not look so bad, but in fact, the kidney is already being affected. We just don't have a way of measuring it very early on. So somebody who's got significant lung or heart abnormality, remember that they've already got kidney abnormality. We just can't measure it in regular practice. Okay, so those basic ideas will help us to understand why it is so important to look at sepsis in children in a very specific and proactive way. It is a pretty common problem. This is data from the US, and there's about a 40,000 case prevalence of severe sepsis every year. And the highest risk is in fact in low birth weight infants, so those under a year old. And that in fact is where the highest mortality tends to occur. Overall mortality is of the order of 10% of all kids that end up in ICU. And respiratory tract sepsis and bloodstream infection are the commonest infections. So if you were here when I spoke about adult sepsis, you might remember that there are some similarities. In other words, the site of infection seems to be similar, but the mortality is different in children, and there's certainly a higher prevalence in certain ages, and the very young are particularly prone. This is an observation of the global causes of mortality. And all told, there are about 9 million deaths in children under the age of 5 each year. Sepsis constitutes 60% of the overall causes of mortality in children globally. Therefore, it is the #1 killer in children. As far as the sources go, remember that I just gave you the US data. In low and middle income countries, pneumonia is still the #1 cause, but then you have diarrheal illness and the tropical and subtropical diseases that are an important contributor to the problem of sepsis. And these require a different approach in thinking, as I'll try and show you. And of course, there's a very regional pattern to the way the high mortality tends to occur. Now, what are the important lessons we've learned? As we've looked at the different areas of our practice, this was an important message that came out. Shock for the emergency department physician is a really important question, because if we are to change the outcome from shock and sepsis, it's important that we offer the treatment necessary as early as possible. And the emergency department physician typically is the first physician contact for the critically ill child. And these physicians, when directed to maintain age-specific heart rate and blood pressure, when they achieve the pulmonary refill of less than 2 or 3 seconds, and when they use inotropes judiciously through peripheral IV access or even intravenous, intraosseous access, when central access is a problem, they make a big difference to the outcome from their needs and infants. So that statement needs to be emphasized. In all of our thinking, we need to be making sure that all of our physician colleagues have the same insight and practice. Again, this is a study looking at a Pittsburgh community. And interesting to understand that a stepwise escalation therapy in the community physician's hands makes a big difference to mortality. So here's a situation where a tertiary center gets cases referred from the community facility, and the community physicians achieve shock reversal in patients, and this was associated with significant survival benefit. And the resuscitation practice was consistent with the guidelines for resuscitation in only a small proportion of patients. So when practice was in agreement with standard guidelines, the mortality was low, 8%. But when the mortality reaches 38, it indicates the non-compliance with the basic guidelines. So again, extending the role of the insights that we have for the community is a very important step. We need to do it with the ED, the community physician, and the clinics that are out there. So that when the patient gets to us, they already have been effectively resuscitated. So what are the key kind of indicators? Very soon I'm going to show you a website which is, to me, the most helpful. The World Federation of Pediatric Intensivists, who have a website indicating all of the necessary facts that you need to know. But these are the kind of key factors that have changed mortality. Every hour that went by without guideline adherence was associated with a 1.4-fold increase in mortality risk. So this is an exponentially increasing mortality. With each hour that the resuscitation is not being applied, there's a dramatic increase in mortality. So it's very important that we treat early and we treat effectively. What are the key pieces to effective treatment? Children require proportionally larger quantities of fluid. They need inotropes and vasodilator therapy as appropriate. And it's okay to use a peripheral line. You can't get a central line, which is not always easy if you haven't done a lot of them. Hydrocortisone is indicated for absolute adrenal insufficiency, and very uncommonly there's a need for ECMO and refractory shock. Now this is clearly in a very quaternary setting. So there's evidence that that intervention makes sense in a very small group of patients. But these three are very important early steps and easily achieved in the hands of many clinicians. I'm going to talk for a few moments about fluid resuscitation because it's a very controversial area, and I'm going to give you my thoughts about how you should think about it. And you can ask me if you don't like what I say. In 2010, there was this description that in fact the evidence for fluids, how much, what fluid to use, was very weak. And there was a suggestion that there was a need for a definitive trial. And in fact, this was the attempt to do the definitive trial. And you might all recall reading the maintenance study where they gave children either 20 or 40 mils per kilogram of either crystalloid or colloid as a bolus. And they compared that to no bolus in children that had severe infection in an African setting. They also had a similar severity of illness, all of the kids in this study. Now what they found was that the mortality in the kids who got 20 mils was 12%, 40 mils was 12%, and the kids who got no bolus was 8%. And it didn't matter whether you used crystalloid or colloid, they were both equally bad. Suggesting in fact that using bolus of fluid is a bad thing. This then produced a review and a commentary in PLOS ONE this year, literally a month ago. And they looked at 13 trials, and they concluded that in fact there was only one study that was of any value, and that was the FEAST study done by Maitland. And they suggested that no bolus was better than bolus in children with general septic shock and malaria. And they also said there's no difference between crystalloid and colloid. But they commented also, importantly, there's no data for dengue or severe malnutrition. So they seem to support the suggestion by Maitland that you should not be using fluids to resuscitate children. And here's the fourth plot that describes why they made that conclusion. And essentially you must look at this little diamond over here. If the diamond is on one or other side of this line, then it means you should or should not be doing that particular thing. And in this case here, what it's showing you is that there was an increase in mortality among the children who received the fluids here. And here it shows that it didn't matter whether you use crystalloid or colloid, there was an increase in mortality among these children. And then if you look at this here, it's a summary description across all of the different studies done. And you see for the most part the diamonds are crossing the line now. And effectively what that means is the data is not convincing. if you put them all together into one bundle and try and measure them. So the suggestion then would be that maybe this one study was not giving us all the information we needed. Now, when you put that into one mindset for yourself, and then say, okay, what is the next step after you've decided about fluids? Well, the next step is to talk about vasopressors. And norepinephrine, epinephrine, and dopamine are the 3 drugs you should be considering. This was a nice summary description because it gives you a good sense of the dosing that you should be using. And they also comment again to remind you, you can give it centrally or peripherally. This was a nice study because it was done in a low income setting in India, where they showed a trend toward early reversal of septic shock by the use of hydrocortisone. Now this is the World Federation of Pediatric Intensive Care Guideline. You can have a copy of this presentation and you can see that website, where you can get a lot more information that corroborates what I'm trying to tell you. And they showed that there was a decrease in mortality when the guideline was applied. And they did make an important distinction about how you should think about the guideline in low and middle income countries. And that's an important thing for us to understand. Because the nature of the reality in the low middle income countries is different, we need to think about how we treat those people differently. Now this is a study by Mitch, Levy, and the surviving sepsis team. And they did this in Europe, in the US and Europe. And in fact, they showed that a large number of patients, when people abided with the compliance, or should I say with the bundles recommended for managing sepsis, mortality significantly decreased over several years. And this was sustained. This study included mostly adults with a few what we would call children. So suggesting in fact that when you again try and abide by guidelines, you do have benefit. This was a study in Brazil, and they showed improved survival from the bundle application or strict goal application. Understanding full well that there was variability in Brazil, given the vast differences in the nature of the country, to apply and adhere to the guideline. So there were some areas where it worked well, and some areas where it didn't work. In Africa, the reality is that less than 2% of countries are actually capable of implementing the surviving sepsis guideline. In the same breath, they are incapable of implementing the pediatric guideline for effective treatment. And it begs the question, are the current guidelines for children or adults applicable in Africa? And the bottom line is that the comprehensive guidelines that we have need to be considered carefully in the context of low and middle income countries. And that's because the human capacity and the infrastructure differences are very different. And your ability to do the things that are recommended is not always the same. So what am I going to leave you with? Well, I think there's little conversation about the fact that you should apply the World Federation of Pediatric Intensive Care Guideline. I will say to you that I totally disagree with the Maitland study observation that you should not be giving to boluses. The recommendation by the World Federation and the recommendation by the adult intensivists is selective bolus administration makes a lot of sense. In the Maitland study, 60% of the patients had malaria. We know that in malaria and dengue fever, bolus administration of fluids is hazardous. Why you would recruit patients who are high risk for developing complication and study a bolus in them makes little sense to me. So it is about saying that you've got to be sensitive to what are the realities in low and middle income countries and modify your protocol accordingly. In developed countries, as much as there seems to be better implementation of the guideline, overall, the absolute application is only around 50%. So half the time people are doing the right thing in terms of implementing the guidelines for the management of sepsis. So when I started off, I told you that there was a lot of beauty and magnificence in the beautiful country that you live in. And here again is this magnificent illustration. Being able to put these one-ton pieces together in this way is just awe-inspiring. And I hope you'll be as inspired as I was when I saw these things. And I leave you again with this reminder for our meeting. I'll be happy to take some questions before the next talk.